Today our topic is National Malaria Control Program. So malaria it's was a major public health problem in India, and it causes widespread morbidity, mortality and economic loss previously. So to combat this, National Malaria Control Program, that was NMCP, was launched in April 1953 by Government of India. So over time, the program evolved through several phases like control, eradication, then resurgence, modified strategies came up, and elimination framework was also there. So it reflected all India's adaptive approach to malaria management. Now we'll talk of historical evaluation. It was launched as NMCP in 1953. It was based on indoor residual spraying with DDT twice yearly in endemic areas. The targeted regions with spleen rates was more than 10%. It was operated for over 5 years. That is known as 5 year national programs, 5 year plans. That was 1953 to 1958. Achievements made during this period was that malaria cases declined from 75 million to 2 million, and a major decline like 80% of reduction was seen. Major dividends were agriculture, land development and industry due to improved productivity. In 1958, when the second 5 year plan came up, so National Malaria Control Program now became National Malaria Eradication Program, because 80% of cases reduced. So uh, everybody was like, we can now have eradication of malaria. Eradication means complete complete decline of malaria cases. So international standards were adopted, and they were adopted with four phases like preparatory, attack, consolidation and then maintenance. So initially it was successful, but resurgence occurred, like the malaria cases rose from 50,000 in 1961 to 6.4 million in 1976 again. Now, what happened? Nobody knows. Then, in 1977, MPO program came. That was the modified plan of operation. So, it was particularly to address resurgence. Why the cases moved up from 50,000 to just multiple fold 6.4 million. So, objectives were to prevent deaths, to reduce morbidity from malaria, to maintain agricultural and industrial productivity, and consolidate earlier gains. So the key feature was the flexibility, which was based on local epidemiological conditions. Then in 1978, malaria control through PHC was introduced. PHC means now at every level of organization, like healthcare delivery system of India, the PHC is the smallest unit. PHC is primary healthcare unit. So PHC, like this program was directly integrated into the PHC system, so that every PHC should work on malaria control, so that the wide coverage can be there, and almost it should be like 100% coverage should be there. So it emphasized on community participation, it emphasized on national commitment and intersectoral cooperation. Peripheral health workers like ANMs and ASHAs, they became central to drug distribution and surveillance system of this malaria control. Then in 1994, Malaria Action Program, again the another resurgence program was developed, and it focused on prediction, early detection and outbreak response at district level. Now anti-malarial month was introduced, and it is every year celebrated as in June for awareness before monsoon. So the main thing is to strengthen health promotion and IEC activities. Now what are IEC activities? That is information, education, communication activities. IEC means information, like we have to give information to the public, how we have to educate them, how we have to communicate things to them. So these activities combinedly uh, have multiple things to be covered, like advertisements in like TV, advertisement on radio, then hoardings and boardings at various places, and some like pamphlets distribution through PHC and CHC at all the hospitals of district hospital. And also the pamphlets can be put on the digital boards in corporate hospitals. So these are various IEC activities. Then urban malarial scheme was also launched, and it targeted the towns with more than 50,000 population, and the positivity rate was where the positivity rate is more than 5%. So it introduced active surveillance in urban areas. Now, in the programs which were before coming up, like we talked of this NMCP first, then NMEP, MPO, then MAP came up. Now, what happened is ki we the program was not foolproof, or the results were not coming, or you can say the outcome was not as such which were expected. So in 1997, enhanced malaria control project was launched, and World Bank was supported it, and it emphasized on community participation. Now the major thing in community participation in malaria control is that if you have plenty, if you have adequate number of plants in your house, you have to go for malarial control measures. Okay, so National Vector Borne Disease Control Program in 2003, it integrated malaria also with other vector borne diseases. National Center for Vector-Borne Disease Control in 2021 became the nodal agency to for malarial elimination, and it is the current nodal agency also. So now what this is whole about the control program, or you can say the eradication program, which came up step by step from 1953 to 2021 till now, and this is the timeline also, you can say. So the way, objectives of malarial control and elimination is to reduce morbidity and mortality, interrupt the transmission, strengthen surveillance system, promote community participation, and achieve malaria elimination by 2030. Now 2030 is the goal set by this program. So, and it is also in line with the WHO targets. Now, what strategies we have to opt in? Number one, vector control, that is, insecticide treated nets should be used. IRS should be used. Case detection, rapid diagnostic tests should be done. Then, surveillance should be very strong. Community engagement should be there. And we have to link malaria control with maternal health, child health, nutritional programs. Means various programs now became the integrated part of all national health programs. Now, what was the achievement? Now, this is the whole, we are talking of achievements from 1953 to this 2022. That is, the malaria cases reduced to 75 million to point 0, sorry, 0.18 million in 2022. And the deaths also dropped to fewer than 100 annually. There were no indigenous cases reported anywhere, and India is on track for malarial elimination by 2030. What are the different challenges that are coming up? Number one challenge is, as the things are moving towards technology and advancements, the mosquitoes also are becoming insecticide resistant. The drugs resistance is also there against Plasmodium falciparum. The new hotspots are being created again and again due to migration and urbanization. The climate change is affecting the vector breeding areas, and the funding and political commitment is always a challenge. So now, if we talk of national framework for malarial elimination till 2030, if we talk of this, then these are the different milestones achieved and what were the targets. Like in 2000, by 2016, it was said that all states should be um, like they should include malarial elimination in health policies. By 2020, there should be no indigenous cases. Then many states and many UTs move to elimination phase. Five category three states move to pre-elimination. This is the coding given to the states and UTs. Okay, so there was national reduction of 15 to 20% if we compared it of by 2014 statistics. So by 22 there were zero indigenous cases in 26 states. Then some states entered elimination phase. By 2024, all states and UTs reduced the API to less than 1 per 1000 population at risk, sustained zero deaths, transmission was interrupted nationwide. By 2027, what the target is that we should have like indigenous transmission interrupted across India, and by 2030, we should have the status of malarial free status nationwide. We should have this establishment, and we should have this like tagline that we are malarial free nationwide. So this is all about your national malaria eradication or control program.